Um, Good afternoon, ladies and gentlemen. Welcome back to the second session in gastrointestinal oncology, and we're carrying on from this morning, where we had a very fascinating and interactive session, and I'm hoping this is going to be similar, if not better. Right. So we have got a good panel here. The first person we've got here is Dr. Habibullah Khan, who's a consultant clinical oncologist at Royal Shrewsbury Hospital in the UK. We also have Dr. Jawad Ahmed, who's a consultant hepatobiliary surgeon, University Hospital Coventry, Warwickshire, and he's going to talk to us about robotic HPB surgery. And then we have Dr. Nadeem Tehami, who's a consultant hepatologist and hepatobiliary physician from Southampton, and he's going to talk about the role of endoscopic ultrasound in hepatobiliary center. So thank you very much for everybody who's joining us. I'm going to hand over to Dr. Habib Khan, who's a consultant clinical oncologist, and he's going to talk to us about total neoadjuvant treatment in rectal cancer. Dr. Habib, thank you very much for joining us so early in the morning.
Thank you very much. Thank you, everybody. I'm just going to start my talk, which is about total neoadjuvant treatment in rectal cancer.
Perfect. We can see you clearly and we can hear you clearly as well. So please go ahead.
Consultant clinical oncologist specializing in lower GI and breast cancers. I'm currently working at Royal Shrewsbury Hospital NHS Trust. I would like to thank Shaukat Khanum Memorial Hospital and all the team for providing me the opportunity to be part of this meeting. Today, I will be presenting on total neoadjuvant treatment in rectal cancer. This is outline of my talk today. I will give a brief review of rectal cancer management under the heading of Introduction and Conventional Options, with a quick review of extended options of both chemo and radiotherapy, then moving on to the results from OPERA, PROTEGE 23, and REPETO trials. I will also have a quick look at its impact on neoadjuvant treatment in rectal cancer, especially towards wait and watch policy and bringing it into the mainstream. Rectal cancer makes up approximately 25% of large bowel cancer in the Western world since 1930. The management of rectal cancers remains a challenge. Colon and rectal cancer has many similar clinical features and are often referred to as colorectal cancers. The genetic profile are very diverse. We know that the right and left colonic cancer outcomes are different, and rectal cancer management is different from colonic cancers. The oncogenesis of rectal cancer is more complex. Few studies have reported that 5-year survival for patients with colonic tumor is better than rectal cancer. There's lack of strong evidence in setting of rectal cancer in support for the use of adjuvant chemotherapy, which is generally extrapolated from the data available for colon cancer. Since 1990s, total mesorectal excision became as an established and superior surgical modality, which established en bloc resection of tumor and nodes by sharp dissection through mesorectal facial planes. In early 2000, the role of radiation started becoming clear, showing reduction in local regional relapse, even with the TME, which let alone improved the outcome. In 2004, the German Rectal Cancer Study Group established preoperative chemoradiotherapy followed by total mesorectal excision as a standard of care for rectal cancer. Although this aggressive trimodal approach achieves low rates of local recurrences, approximately about 5%, distant metastasis rates exceeded 25%. T1 to T2 and 0 usually require surgery. Anything stage T3B or above in rectal cancer require multi-modality approach, even short course or in the form of long course chemoradiotherapy. The history of radiation in rectal cancer goes back to 1970s, with trials showing radiation and surgery alone or combination. Meta-analysis of 22 randomized controlled trials has shown that perioperative chemoradiotherapy reduces local recurrence with no impact on overall survival. 1990s, postoperative chemoradiation becomes standard option of treatment, and early 2000 showing preoperative chemoradiotherapy was more effective and less toxic. Interest grew over adding oxaliplatin to 5-FU, but it did not improve outcomes, but with increased toxicity. Moving on to using capecitabine era, it's shown that it is equivalent to IV infusion of 5-FU combined with radiotherapy. And more interest grew over using short course versus long course. The question arises, what is the best radiotherapy regime to be used in rectal cancer? We know the short course radiation is an alternative to the long course chemoradiotherapy, which was established by German Rectal Cancer Study Group and the Polish study groups. Although there were initial concerns for lack of downstaging of bulky tumor and inferior outcomes with low-lying tumors with short course radiation. The addition of delay following short course radiation, during which chemotherapy can be delivered prior to TME, has resulted in outcomes comparable to chemoradiation. The recent advances in the management of rectal cancer have centered around a reduction in local and distant relapses and incorporating the modern radiotherapy techniques, including IMRT, VMET, along with chemotherapy. The approach towards optimal approach has been addressed with STAR, ECHO trial, and more recently with OPERA, PRODIGE 23, RAPIDO, and now providing additional insight. These trials enroll patients with high-risk disease, those with T4AB or N2 disease, extramural venous invasion, involved mesorectal fascia, or enlarged lateral pelvic wall lymph nodes. After single-agent 5-FU established its role in colorectal carcinoma, the combination treatment have demonstrated increased efficacy compared with 5-FU and leucovoridil alone in randomized studies. These data established that in metastatic colorectal cancer, a more active first-line treatment can also more effective in terms of improved progression-free survival and overall survival. We know that exposure of metastatic colorectal cancer patients to all three most active agents, irrespective of their sequence, is associated with promising survival. Moreover, a pooled analysis of 7 phase 3 trials demonstrated that survival is correlated with proportion of patients who receive all three active drugs in the course of their disease, but not with the proportion of patients who receive any second-line treatment. This analysis also shows that in a sequential strategy, not all patients who progress after first-line chemotherapy are able to receive second-line treatment, and therefore can be exposed to all three agents upfront. In summary, treatment such as folfixiri represents the first studied combination to be superior to an infusional 5-FU containing doublet, and its improvement in efficacy, coupled with a manageable toxicity profile, support the use of folfixiri as a first-line option of care for selected patients with metastatic colorectal cancer. Now, as we approach towards the new era of targeted agents, we are always ready to push the boundaries with these agents' role in locally advanced rectal cancer as a new adjuvant treatment. We believe that the use of folfixiri should be of particular interest in this approach, and perhaps also in patients with few chances to achieve a 3-drug exposure in a sequential strategy. Future development should evaluate the integration of folfixiri with targeted agents. Before we proceed any further, we need to have clear concept as which patient will benefit from total neoadjuvant treatment. In simple terms, these are the patients who, if underwent surgery, would likely require post-operative chemoradiotherapy. Data from randomized trials and meta-analysis suggest that the preoperative approach is associated with a more favorable long-term toxicity profile and fewer local recurrences than postoperative treatment. All patients with T3 and 0 rectal adenocarcinoma needs comprehensive evaluation by endoscopic ultrasound or MRI before neoadjuvant treatment. Others have questioned the utility of upfront chemoradiotherapy for patients with T3 and 0 tumors, particularly those involving the upper rectum, given the favorable low rates of local recurrence after TME alone, which was shown in the TOUCH trial and several retrospective analyses. A number of studies have shown that T3 tumors with greater than 5 mm per extramural invasion have a higher rate of nodal involvement. Nevertheless, neoadjuvant therapy should be considered in patients with clinically node-positive involvement shown on radiological studies such as MRI and endoscopic ultrasound, which has been staged T1, T2 rectal adenocarcinoma, or the tumor that appears to invade or threaten the mesorectal fascia on preoperative imaging. Because of the decreased likelihood of achieving a tumor-free CRM with upfront surgery. On the other hand, the use of preoperative therapy for a distal T1 or T2 rectal cancer is an attempt to convert the operation from needed APR into low anterior resection or prostatectomy with coloanal anastomosis, which is still controversial and not being established, but it is an accepted standard of care, but is considered regularly. Conventional chemoradiotherapy did not address the issue of micrometastatic disease, which may need to be prioritized. Hence, the idea of total neoadjuvant treatment is to address that issue with chemotherapy followed by chemoradiation or vice versa. Where addressing the micrometastatic disease is prioritized over addressing local disease with earlier chemoradiation. In addition, there is concern that the prolonged delay between the completion of radiation and surgery may lead to increased surgical morbidity resulting from pelvic fibrosis and wound healing complications. On the other hand, extending time to surgery following radiation can also allow more time for tumor downstaging and increased rates of complete responses. The optimal time has been shown by different trials. Delayed to surgery, the Lion R9001 trial showed higher rates of complete pathological response or near complete pathological response, which were in the region of 26% versus 10%, with a 6 to 8 weeks delay to TME compared with 2-week delay. Similar Stockholm 3 trial also showed that the 4 to 8 weeks delay to TME following radiation was associated with improved pathological complete response. More prolonged delay seemed to increase complications, as shown by Grecar 6 study, that waiting for more than 11 weeks after chemoradiation for TME did not further increase rate of PCR and was associated with increased surgical morbidity as a result of increased medical complications and poor quality TME. Now we're going to look at the 3 major trials recently presented, which include OPERA, PRODIGE, and RAPIDO trial. Organ preservation with wait and watch strategy is OPERA trial, with the main aim of the study was to look into the patient with optimal radiation chemotherapy sequences for organ preservation. It included 324 patients enrolled for stage 2 and 3 rectal cancer, which were treated with 5FU radiation along with chemotherapy doublet agent, either KFOX or FOLFOX. Most of the people were restaged 8 to 12 weeks after finishing treatment, total neoadjuvant treatment, and were assessed with digital rectal examination, flexible sigmoidoscopy, and MRI scan. Patients with complete or near complete clinical responses were offered wait and watch policy. Incomplete responses had total mesorectal excision. This shows the OPERA protocol scheme. We know that the initial results showed that upfront chemoradiation resulted in higher rates of organ preservation, 58% versus 43% at 3 years, with significant p-value, and there was no difference in distant metastasis-free survival, disease-free survival, or compliance between the two arms. If you look at the PRODIGE 23, which was a multi-center randomized open-label phase 3 trial looking at the neoadjuvant role of FOLFIRINOX before preoperative chemoradiation with TME surgery and adjuvant chemotherapy in resectable locally advanced rectal cancer. It is a phase 3 multi-center randomized trial. Eligible patient population was more similar to OPERA trial, including T3, T4, 0 rectal adenocarcinomas, which were less than 15 centimeter from anal verge, with good performance status, less than or equal to 1. This shows the study design of PRODIGE 23 with median follow-up of 46.5 months. It showed that 3-year disease-free survival was better with upfront chemo radiotherapy with FOLFIRINOX, 75% to 68.5%, and 3-year metastatic-free survival was 78% compared to 71%. Local relapses were also decreased, and in the neoadjuvant chemotherapy arm, it was 4.8% compared to 7%. And similarly showing improvement in YPT0 and YPN0 status of the disease. If you look at the toxicity in PRODIGE 23 trial, it shows significant improvement in overall global health status and quality of life over time. The grade 3 and 4 toxicities were majorly neutropenia, diarrhea, fatigue, nausea, and vomiting. Rest of the toxicities were acceptable and comparable to other treatment. If you look at the feasibility of FOLFIRINOX in stage 2 and 3 cancers, we know that the neoadjuvant FOLFIRINOX increases probability of complete pathological response, decreased probability of surgery with non-curative intent, improved disease-free survival, and metastasis-free survival. FOLFIRINOX in stage 2 and 3 rectal cancer considered a new standard of care for initial management of T3 and T4 rectal cancers. We're now going to look at RAPIDO trial. This is a randomized phase 3 international trial. The main objective of this trial was to look at the decreased disease-related treatment failure and distant metastasis. This trial looked into short course radiotherapy followed by delayed surgery with, in the waiting period, with chemotherapy, mainly to better compliance, downstaging, and fewer distant metastasis. It included the high-risk rectal cancers, as previously stated, and the schema study design was patient were randomized either to short course radiotherapy, followed by 6 cycles of K-POX or 9 cycles of FOLFOX, followed by total mesorectal excision, or they were either randomized to capecitabine-based chemoradiation upfront, followed by total mesorectal excision, and then adjuvant chemotherapy with 8 cycles of K-POX or 12 cycles of FOLFOX. The primary endpoint was disease-related treatment failure, and secondary endpoints included overall survival, R0 rate, complete pathological response, toxicity, and surgical complications.
Dr. Khan, we've got 5 minutes.
If you look at the disease results, it showed that between June 2011 and June 2016, at 3 years, the cumulative probability of disease-related treatment-free treatment failure was 23.7% in the experimental arm and 30.4% in the standard arm. Pathological complete response rates were 27.7 versus 13.8 in the experimental and the standard arm, respectively. There was no difference in distant disease-related treatment failure between hospital with or without policy for post-operative chemotherapy. Local regional failure were also shown 8.7 versus 6% respectively. If you look at the pros and cons of total neoadjuvant treatment, we know that FOLFOX and CAPOX are the standard chemotherapy regimes used for colorectal cancer, and efforts are being taken
Dr. Khan, 3 minutes.
chemotherapy with neoadjuvant radiation for rectal cancer, which have resulted in higher rates of toxicity without a clear benefit. The addition of experimental agents to FOLFOX-based total neoadjuvant treatment has also been investigated in previous trials, but recent evidence is showing acceptable toxicity with good outcome. But if you look at the risk of disease, the cons are that we have a risk of disease progression, upfront treatment risk of toxicity, delayed surgery, subclassification of high to low risk, evidence emerging in the weight watch policy. In my final concentration, we have to understand that if total neoadjuvant treatment is chosen and giving chemotherapy first, we should do early assessment with scans after 2 months of chemotherapy and move directly to chemoradiotherapy if no response is seen. This is particularly important in the setting of a tumor with deficient MMR, as these may be resistant to neoadjuvant treatment. During the chemotherapy portion of treatment, we need to use combination with oxaliplatin-based chemotherapy rather than fluoropyrimidine on its own. The options include FOLFOX or FOLFIRINOX, as
Dr. Khan, you have 1 minute.
for the 23 study. And if you're using chemotherapy up front, no more than 4 months of treatment of oxaliplatin-based chemotherapy is needed. While TNT is emerging as a new standard for the treatment of locally advanced rectal cancer, there are several controversial and unresolved issues. In final consideration, especially with respect to radiotherapy, we know we need to consider long course chemoradiotherapy, which have shown significant benefit. Short course do have its own role, especially in the current COVID-19 situation. We need to make sure the time from radiotherapy to surgery may be an important mechanism which cause benefit of total neoadjuvant treatment, lending support to administering radiotherapy first, followed by chemotherapy. But there are no trials directly comparing different sequences of therapy of either long course chemoradiotherapy or short course radiotherapy. Organ preservation needs to be considered carefully after discussion in the MDT and with patient. There are further options which can be considered, such as contact radiotherapy and SBRT, which needs further evaluation.
Okay, thank you so very much, Dr. Khan. That was quite enlightening, especially to know about all the updates in the neoadjuvant radiotherapy. If it's okay with you, we will take the questions at the end so that we can have a panel discussion. Okay, perfect. So next we have Dr. Jawad Ahmed, who's a consultant hepatobiliary surgeon at Coventry Hospital. He's the lead for robotic surgery in HPB, and he's been trailblazing with robotics in HPB surgery in the UK. So it would be very interesting to know how he's performing over there and what interesting thing he has got for us today. Dr. Jawad, if you could please put up your slide, and we'll let you know if you can see. So we can see your slide clearly. If you can speak as well, then we would know if we can hear you at the same time.
Good morning.
Perfect. We can hear you as well.
Fantastic.
So the screen is yours. Please go ahead.
Thank you, Irfan. It's such a pleasure to present at this prestigious conference as always. It's such an honor to be part of this great symposium. It's a shame that we're doing it virtual because I was looking forward to coming to Pakistan and meeting you guys, but here we go. Anyway, so I've been tasked with presenting our robotic experience in the UK. So I thought, let's give a little roundup on what's happening on all the different platforms. So this is how my talk is divided. I'll talk about international update, what's going on worldwide, national update in the UK, what's happening in Coventry, and just like for some good measure and keep you guys interested, share some of my bloopers. So let's talk about the international update. So in the last like few years, 3 to 5 years, there has been an explosion of robotic surgery practice all over the world. People have been buying robots right, left, and center, and the robots are becoming cheaper. The consumables are becoming cheaper, and lots of people are getting it. Data is emerging, and strong data, compelling, showing that robotic surgery is maybe better in many cases than open, and is the future of surgery. To just give you some example, if you search the PubMed and put in robotic and pancreas, you will see like lots of publications over there, and especially in the last couple of years. And these are mostly in major resections. And evidence is emerging, like, for example, from Chicago, 500 robotic pancreatodectomies in 10 years, which is an amazing number. I don't think I will ever reach that in the UK in my lifetime, because none of the centers in the UK are high volume, unfortunately. So the best center in the UK do about like 90 cases per year, and then for one surgeon, it is not possible. So for 90 cases per year doing Whipples, there's about like eight surgeons. So each surgeon in the UK tends to get about 10 to 12 Whipples per year. So doing 500 in my lifetime, I don't think that's possible in the UK. But data is emerging, like, so talking about that robotic pancreatodectomy is better in especially soft pancreas and smaller ducts. And I think I agree with that, but this is my experience as well, that it is better to do robotic anastomosis than open anastomosis in soft pancreas and small duct. Robotic vascular sections are becoming common, and people are just pushing the boundaries. So pancreatic surgery is taken off with a robot and with some very good outcomes. And when you search the PubMed with robotic and liver, again, there are lots of publications, but not as many as pancreatic. And interestingly, when you search for major hepatectomies, it has not become very popular, unfortunately, as compared to laparoscopic surgery. The main reason for that is parenchymal transection. Presently, we do not have an ideal or a nicer tool to do parenchymal transection with during robotic surgery. In laparoscopic surgery, the surgeon can use laparoscopic CUSA, and that can give you control over bleeding or identify the pedicles. In robotics, there's not much space between the arms of the robot, so we struggle to do major hepatectomy. I've done a few, and this is my experience as well. But data says laparoscopic and robotic major hepatectomy are equivalent. There's no advantage in doing one over the other, but disadvantage in hard to reach areas. For example, posterior superior segment, which are very difficult to access with the standard laparoscopic instruments, are easily accessible with the robot. And again, the choroid lobe and difficult to dissect areas, which are just quite challenging to approach with the standard laparoscopic instruments. So that's where the robotic surgery has definitely a value. And going to ALPS, people have started doing the first stage of the ALPS with the robot, and it is they present some very good outcomes. So in summary, international platform, robotic pancreatic surgery has flourished, and evidence is supporting its safety and superiority over laparoscopic and open resection both. So it is better than laparoscopic pancreatic surgery. Robotic major liver resections have similar outcome to laparoscopic surgery, but the robotic liver resection is superior to standard laparoscopic approach in hard to reach areas. This was an international scenario. Now, talking about the UK, we are in a bit of a trouble. Brexit and then this COVID, gosh, we are in double trouble. We will get out of it, but it will take about 10 years at least, maybe more. Presently, there are only 2 centers in the UK that offer major robotic centers, and we are lucky to be one of them. No new robotic programs, there's no funding. Existing programs are struggling to continue. COVID, capacity, money, different problems. Yeah, that's what the UK is about. And the local update, what's happening in Coventry? I work at a teaching hospital, which is 1,100 beds hospital in Coventry, quite a major center. But we are low volume. We don't do many resections per year. So our program started in April 2018, and as part of the program. So what happened was 5 years ago there was a surgeon in the UK who wanted to do a robotic cardiothoracic surgery, and he started doing a robotic valve replacement. He did not have full training and did not go through structured modular training program, and they just started some simulation training and brought in a friend to do the surgery. Unfortunately, the patient died on the table. Patient had a complication on the table and then died later on, and that was a huge scandal. And since then, starting a new program in the UK is very, very difficult. We have to go through lots of bureaucratic workup, and we have to do some benign cases like gallbladders and cysts and show that we are safe and we are keeping the data prospectively and all those things. So initially we were asked to do, so two surgeons started the program in our hospital because we always have to buddy up. So I was asked to find someone and then do about 22 cholecystectomies before I could do something else. And that's what we had done. Initially, we did about 24 cholecystectomies, and then we have not done them again. HPB, the way it works in the UK is that there are 52 weeks in a year, and excluding annual leaves and study leaves, there are only 44 working weeks. So one surgeon gets one lease per week. And we are low volume center, so we don't have high numbers. But I have switched 80% of my HPB practice from lab or open to robotic. I do everything robotic, whatever is possible, apart from extended hepatectomy or a vascular resection. So these are like our numbers in the last 18 months, 2 years. So distal pancreatectomy, Whipple's, liver resection, major resection, CBD exploration, gastrointestinal, just like even CBD exploration, I've done robotic because I'm not going back to laparoscopy. And the outcomes are decent so far. We have only about 14% complication rate, which are like all detailed here. We maintain a very strict prospective database because we have to justify the use of the robot and make sure that it is a safe practice, and then it has some advantage for the patients, both short and long term, and demonstrate that our length of stay in the hospital, in the ward, and in HTO is shorter than open surgery. And they ask us to demonstrate it's better than laparoscopic surgery. It's not. Both laparoscopic surgery and robotic surgery are the same thing. They are both minimally invasive procedures. Robotic is done with robotic assistance. So it is difficult to just to demonstrate that robotic is the length of stay is shorter as compared to laparoscopic surgery, but it's definitely better than open surgery. So what happened in commentary, like when pandemic hit us and we were in lockdown in March, our program was stopped because initially there was concern about aerosol generation, and all laparoscopic surgery was stopped in the UK for a few days, and a few weeks. And our robot was taken out of the hospital and sent to private hospital to make capacity and physical space. So we lost the program for like nearly 6 months. But then we were very lucky that we were able to convince our management to buy a new robot. So now we have the latest XI system just like 2 months ago. We got a very good deal because the companies are desperate to sell their robot. So we did not have to pay anything upfront. They are charging us on per case basis. So we pay them for every case we do. And the running cost is lower. At the same time, they have also rolled out an extended use program. I feel this table is not very big, but if you look at the figures, so they have reduced the price of the instruments as per use. Previously, the needle holder was £1,960 for 10 uses, and now they have increased the price to 2,230, but the uses have been extended to 15. And in some cases, they have been extended to, in this case, the price has remained the same, rather slightly cheaper. The long tip forceps, the previous price was lower, now and they have extended the uses. So the robotic surgery in our center has become cheaper by 20%. So we are back in business. This is a new robot, just to give it a glimpse. It has a huge big platform. We don't have to do much. It just align to the patient and the arms roll out and then align themselves to the patient and gives you an indication where to make an incision and all that. So it is quite a exciting machine. So local update, we acquired a new robot and robotic program is back on track. We are further on our learning curve. We are learning, and I'm telling you, we are learning by mistakes, and I'm going to share some of them with you. So I'll show you 4 videos in the next 13 minutes to finish off my talk. And then this will be on the liver and pancreas both. So during robotic liver resection, bleeding is the most common problem. Doing highlight dissection is no problem because the robotic instruments are fantastic in doing the vascular and the biliary dissection and mobilize the liver, not a problem. But when it comes to the parenchyma, it is not ideal because we can't use CUSA. This is quite there's not much space between 2 arms of the robot, and you have to have a second consultant who scrub and does a parenchyma transaction. Obviously, that would be ideal. So we end up using bipolar, monopolar, harmonic, which is not endoricid, and basal sealer. So the management of bleeding during robotic liver surgery is prevention. That's the best management. Pressure, pneumoperitoneum, increase the pneumoperitoneum, packing patients, and Pringle. So this is a short video about 4.5 minutes. We're doing a right hepatectomy. We have done the hilum and we have secured the right portal vein, right hepatic artery. Liver is fully mobilized, and we are doing the parenchyma transaction with harmonic. So the first 2 centimeters can be done easily. But the problem with harmonic is that tip becomes very hot. And the hot tips, if it touches the vein, especially hepatic veins, it makes a hole in the vein. And then we have this annoying sort of trickle of blood. But it's not a huge amount, but it just keeps on leaking. So we have to somehow secure it. So at this stage, we can use bipolar in the right hand, and the assistant in the middle is trickling in some saline to keep the area wet, because by doing this, we can avoid jarring of the tip of the instruments. So that's how bleeding can be stopped by just a sheer perseverance and just staying at it. So we are further on, and the specimen has been dissected mostly, and then we are going to the last part of the resection. And this is the hepatic vein that we thought we can secure with the stapler. Obviously, this was, I think, case number 3. And so we were not enough adequately experienced. So we fired a stapler a little bit too premature and obviously caused some bleeding. So this is bleeding from the hepatic vein, we think, because it has not been completely taken by the stapler. There's a bit of a panic in the room. As you can see, surgeon is just suddenly not sure what to do. And the assistant is sucking on the blood, which is okay. It doesn't look like a huge amount of bleeding, but it's still uncontrolled. We have to do something about it. So the technique is packing, pressure, and pneumoperitoneum. While doing the pneumo, we need to be sure that there's no major vein which is completely open, and then you don't want to cause CO2 embolism. But packing is the best measure. So ask assistant to throw in a swab. Assistant is a little bit nervous, and swab is coming in. It will come at some stage. And when the swab comes in, the camera will become fuzzy and will lose view. It happens all the time. So the swab is coming. So this is a Murphy's law. Whenever you're doing a minimal invasive surgery and there's a bleeding or trouble, the camera will become fuzzy. You will have to clean the camera and that slightly added stress. So pressure and then be patient. Clean the camera, come back in and do some cleaning. This doesn't seem to be too much bleeding there. But you can be patient, give it a few more minutes, at least 2 minutes. And then take the swab gently off. It has slowed down, but don't think the bleeding is controlled. So we need to do a little bit more dissection there. But in this Uzi area, dissection probably will be quite difficult because we won't be able to see things clearly and we lose some blood. And we don't like losing blood. So at this stage, we will probably do something more. I think the only thing we are left with is Pringles. So we place a Pringles tape at the beginning of the procedure. So far, in this case, we had not used Pringles, so I think it was time to use it. So we grab the bleeding point with bipolar and then just
Dr. Chipad,
push.
you have 5 minutes.
Oh, okay. Do I not have 8 minutes? Okay. So, and then we slide the snugger onto the porta hepatis and control the bleeding. And that's how the bleeding stops usually. Okay. So the common problems during pancreatic surgery is failure to progress, difficult anatomy, bleedings, and small pancreatic duct. And the treatment is obviously experienced. So we're doing a Whipple's procedure over here. You can see this is the SMV, and that's the SMA over here. This is the Ansonet process. You can see the robotic instruments are quite endoresident. They can go hard to reach areas. So we were a little bit too blasé over here. And then I think this is a branch from the SMA. That's the SMA over here. And we obviously caused some bleeding by being a little bit not very careful. So bleeding during robotic surgery looks quite horrendous because the view is so much magnified and everybody's watching you. There's a bit of a panic there. But the management is to just, again, put a swab on this bleeding and press it and just wait. Try to suture the bleeding site. Now, with the arterial bleeding, if the artery is completely transected, it will go into spasm and will retract. And bleeding stops at that time. But then it always bleeds again in the postoperative setting. So it is better to identify the bleeding vessel and then suture it. So we've identified the bleeding vessel over there. I'm trying to rush this video through because I thought I had a little bit more time, but the time flies when you're having fun. So that's a bleeding vessel that we have secured, and without losing too much blood, we were able to carry on. Another case, so this was interesting. So we were looking for pancreatic duct. This patient had a duodenal adenocarcinoma, and so obviously did not have a dilated pancreatic duct. And as for the CT scan, the duct should have been over here. So that's the pancreas, SMV, and splenic vein and portal vein. So the duct was supposed to be here, and we could not find it. This is a 5 French feeding tube. So its diameter is 2 millimeters. We could not find it. So we thought let's use a lacrimal tube, lacrimal duct catheter, which is about 1 millimeter, and see if we can find the duct. We still could not find it. So we kept on pushing, and unfortunately made a false passage. If you look at this area, I'm just pushing the catheter through there. Just keep an eye over there. You will see in a second my glorious work. Yeah, it's coming on. So there's a catheter tip. So luckily, we did not make a hole in the pancreatic capsule. So we're able to immediately retract this and then suture it later on and then find the pancreatic duct adjacent to that false passage. So then we upsize it with a proper stand and did the anastomosis. The patient did not have pancreatic leak. It was just lucky that we got away with it. Patient did not even have a biochemical leak, which was really lucky. And another last video is when we're doing a Whipple's again with a new robot just 3 weeks ago, and we could not find the duct again because this patient had a lower CVD cholangio, and the pancreas is so soft, and we just could not find the duct. So we just had to refashion the pancreas. The duct is like not apparent, so we just had to refashion the pancreas with the scissors and monopolar diathermy. I did not use much diathermy. You can see the pancreas is so soft. It does bleed when you are cutting it sharp, but this is what we have to do sometimes. So when you're cutting it, you just need to be very, very careful and keep an eye on possible side of the duct, which is just at this area. You can see a little bit of juice coming over this there. pancreatic juice. So
you have 3 minutes.
okay, I think I'll finish sooner. Uh, and then this is the duct that we identified, and that duct looks okay, but still about 2 millimeters. And then we can put in a stent in this duct, which is again a 5 French feeding tube, which is about 2 millimeter size. And we can do the anastomosis on this duct. The patient had a large IPMN over there that we chose not to excise, because if we go and excise this IPMN, we ended up, we probably had to end up doing a total pancreatectomy. So what we do is, like, we video record all our major procedures, and we review all the videos critically, and we criticize ourselves. We just be honest with ourselves and say, well, what could I have done better? Economy of movement, any mistakes, anything that we could have done better, retraction, different instruments, different setup. We just have to be honest with ourselves and just like say, what can we do to improve our times and the efficiency. So in conclusion, Mr. Chairman, ladies and gentlemen, robotic HPB has become popular worldwide. It has shown established safety profile now. Robotic HPB is complex and requires training and experience. Major resections should be done by 2 consultants, 1 consultant on the platform and other one onto the patient scrub in case of any problem like bleeding or difficulties. Patient safety must remain at the heart of robotic surgery. We must not continue doing robotic surgery if we think that we cannot do it or patients are coming to harm. That's not the point. Patient is at the center of everything, and patient safety must remain at the heart of the robotic surgery. Thank you very much.
Dr. Jawad, I know you're on call and you have to go, so we'll ask you a few questions very
Yeah,
quickly.
please go ahead.
Ahmed Uzair Qureshi wants to know that if you have to take the camera out every time it gets blurred in the robotic surgery.
Yes, we have to take, well, not really. If the camera becomes fuzzy or blurry, then obviously it needs to be cleaned. It doesn't auto clean itself. So yes, we have to take the camera out.
Okay. The second question is, after open subtotal pancreatectomy, if there is local recurrence, can laparoscopic resection be redone?
Laparoscopic, yes. Robotic as well. People have done. It all depends upon experience, how many cases you've done. So I've shown you paper from Chicago. They have done 500 papers in 10 years. So and then now they're doing like the vascular dissections, and they are replacing the portal vein with the graft and all that. And all depends upon experience. So if you have lots of experience, then anything is possible. A robotic platform is just fantastic. Yes.
Okay. Can I just ask one last question before we let you go? What's the difference between the old Da Vinci and the new Z? What has your experience been?
So the newer Da Vinci has less bulky hands, less bulky arms, and it is on a platform. So the anesthetist, so obviously the old SI model used to come from the patient's head, the head side, and the anesthetist had trouble getting access to the patient's head. The new Da Vinci can be on the patient's right or the left side, and is quite versatile. So it stays away from the patient. So there's lots of space to move around the patient. That's number one. The instruments are all 8 millimeters. The camera previously was 12 millimeter, and the new camera is 8 millimeter. And that has the advantage that you can move the camera from one port to the other port. So all ports are of the same size, and the arms are less bulky.
Okay, perfect. I must say thank you very much for sharing that. It takes a brave surgeon to show his blunders, as you call them. But we learn every day, and every day is a learning curve for us, no matter how senior or experienced you get. So thank you very much for being so honest and upfront with us with your
It's a
learning
pleasure.
curve.
Thanks for having me. Thank you.
Thank you so very much. We'll let you get on with your on call.
Thank you. Bye-bye.
Right, thank you. Next, we have Dr. Nadeem Tehami. He's a consultant hepatology hepatobiliary physician. He's going to talk to us about the role of endoscopic ultrasound in HBV diseases. As we all know, staging and ensuring what the anatomy is and what the disease is doing is crucial in any hepatobiliary disease. And endoscopic ultrasound has made huge advances recently. So it's going to be very interesting to hear from him regarding what's been happening in that role. Thank you very much for joining us, Dr. Tehani.
For having me. Let me just make sure you can see my slides.
Yes, I can see your slides and we can hear you clearly. So you have the floor and you can speak.
Okay, so thank you very much for the invitation. The title of my talk is to discuss the role of endoscopic ultrasound scan in the pancreatic cancers. So after those two exciting talks, I'll take you to the world of black and white. Remit of the session is to briefly introduce the concept of endoscopic ultrasound scan. I believe we've got mainly oncologist audience and a few gastroenterologists. I will then discuss the role of EUS as diagnostic and interventional modality, keeping in the future of precision medicine in mind. So the endoscopic ultrasound scan, we owe the modality of ultrasound scan to this Italian scientist, curious scientist, Lazzaro Saplazzani, who through his observation discovered the skills of echolocation skills of bats, and which paved the way for the development of the ultrasound scan, and then endoscopic ultrasound scan. EUS has been
sorry
around.
to interrupt there. Could you also start your video? We can't see you.
There we go.
Perfect.
So endoscopic ultrasound scan essentially is a combination of two modalities, ultrasound scan and endoscopy. It's been around for at least last 3 to 4 decades. It provides us a very high resolution, but with low penetration. It is quite accurate. We know it's safe. We know it does not involve radiation exposure like standard ultrasound scan, and does not involve any nephrotoxic contrast. The scopes have improved over the years. We have scopes which with much larger therapeutic channels, and therefore we are able to offer many therapeutic options to our patients with pancreatic cancer and otherwise. There are different types of scopes available. The two common scopes are radial scope and a linear scope. Radial scope scan in plane perpendicular to the axis of the scope, whereas a linear scope scan in plane axis parallel to the axis of the scope. It has a wider therapeutic channel, therefore it can accommodate biopsy, needle, and other accessories to offer intervention. This will not come to most of you as a surprise, because we all recognize that pancreatic cancer has the lowest survival of all the common cancers. Only about 1 out of 10 patients end up getting resection, and only 2 out of 10 end up getting chemotherapy. Patients mostly present late. The two common presentation is painless jaundice, and also those with non-specific symptoms with dilated ducts and abnormal liver biochemistry. The challenges remain that unfortunately the survival remains poor despite the best surgical techniques and the oncological treatment available. And it's partly down to not having access to the screening test and the limitation of the diagnostic tests. So what we will do is we will discuss the role of the endoscopic ultrasound scan, focusing mainly on the diagnosis. And then we will touch upon staging, palliative therapy, and some of the other pancreatic cancer treatment. So the focus of this talk mainly is on the pancreatic cancer. Now I'll start off by sharing a couple of case vignettes. And the reason I want to share them is because this is something majority of us come across in our daily practice. And these case vignettes hopefully should have some take-home points. So this was a 77-year-old man who had presented with vague abdominal discomfort. And his routine blood test showed significantly elevated alkaline phosphatase and transaminases. He was not jaundiced. He went on to have an endoscopic ultrasound scan, which suggested slight dilatation of his bile duct. He then had a CT scan, and as you see, the report of the CT scan suggested a malignant process centered in the hepatoduodenal ligament, causing degree of biliary obstruction. It was reported that dominant mass lesion appeared almost extrinsic to the bile duct, and therefore may represent diseased lymphadenopathy. So after further discussion, we plan to do an endoscopic ultrasound scan, mainly looking for that lymphadenopathy and try to sample the lymphadenopathy. And surprise, surprise, what you see on this image is that his duct was dilated as we knew, but inside the duct, there was a hyperaquagenicity within the duct. And behind that aquagenicity, what we call had a posterior acoustic shadowing. So essentially all he had this huge sludge ball in his bile duct. He did have a few lymph nodes which were sampled, which were completely benign. He went on to have an ERCP, and his duct cleared, and his liver test improved remarkably afterwards. Two further cases. One on your left is of a 53-year-old lady who had a Whipple resection for a pancreatic cancer. Following that, 18 months later, she presented with symptoms of nausea and vomiting. She went on to have imaging, including CT and then PET, because initial CT did not demonstrate any obvious explanation. Clearly, the concern was if there was a disease recurrence, which was not picked up on CT PET either. So there wasn't any significant metabolic activity at the site of anastomosis. But when we performed the endoscopic ultrasound scan, he had evidence of disease recurrence at the site of anastomosis at pancreaticojejunostomy, which was sampled, and it confirmed the recurrence of the disease. And third and the final case for discussion at this stage is of a 58-year-old man. And this is quite exciting because he had, again, some weight loss with abdominal pain and went on to have a CT scan, which reported that he had a pancreatic lesion. Now, I don't have a CT scan available to show you, but when we did a EUS on him, and what we saw that all he had is this two-tone differentiation, which we know from our embryology, the dorsal and the ventral pancreas looks different. So what we saw is ventral and then the dorsal pancreas. And what a CT also did not appreciate was this small 1 centimeter neuroendocrine tumor. So in this case particular, CT reported just two-tone differentiation as a pancreatic lesion, and also missed a small net. So hopefully those three cases would have highlighted the importance of endoscopic ultrasound scan in the diagnostic pathways for patients with suspected pancreatobiliary malignancies. I'm going to share some quality performance indicators from Scottish government. I picked up a few QPIs, but I'm just going to focus on this QPI 7, which talks about that patient with pancreatic, duodenal, or distal biliary cancers planned for non-surgical treatment should have a cytological or histological diagnosis. And then the target set is only 75, as you see on the right side of the screen. Now, the imaging modalities that we have available include ultrasound scan and CT, MRI, which is available in most centers. Then some patients end up needing, especially for the pancreatic cancer, PET scan. But if we compare those modalities with the endoscopic ultrasound scan, it has high anatomical resolution and allows diagnostic sampling. It cannot, unfortunately, stage the tumor other than locally. It is obviously dependent on operator, machine, and the patient, but it is highly sensitive compared to other modalities. There are a number of trials available, and they all looked at the sensitivity, specificity, positive, and the negative predictive value of EUS comparison with other cross-sectional imaging. And in all those different domains, endoscopic ultrasound scan stands out. And it mostly, especially if you look at these small size tumor which are sort of less than 2 to 3 centimeter, it outperforms CT by miles. Therefore, we can conclude safely that main benefits of endoscopic ultrasound scan is of EUS over CT is in detection of the small lesions. Now, what question do we ask ourselves once we have discovered a pancreatic mass? The question is obviously the mass, is it resectable? And if it is, then what is the best test to determine the resectability? and if the tissue diagnosis is required, and if it is, then what would be the best method to do it. Now, if you look at the EUS in assessing the resectability of the pancreatic cancer, um, purely looking at the numbers, so I don't know if you're a believer in p-value or not, but it does seem to tend to do better than other cross-section imaging. However, the P, or statistically, none of these tests showed statistical significance. And in real life practice, we agree and with that, because in our MDTs, we do not rely on endoscopic ultrasound scan on making a decision about the resectability of a definite pancreatic cancer. And I'll come back to it in a bit. But from the studies, what we can safely conclude is that CT MR with endoscopic ultrasound scan is more accurate than either alone. I can share another case at this stage of a young man who was 39 years of age, who had presented with painless jaundice. His CT scan did not pick up any solid mass lesion. He went on to have a ERCP because his bilirubin was around 250. Now, ERCP unfortunately caused pancreatitis, and I'm sure surgeons in the audience, and if Mr. Ahmed is still there, would agree with me that once a patient develops pancreatitis, then all surgical plans are lost. So surgeons do not have that clear surgical field. So this young lad had a pancreatitis, and he became a cancer which was operable became inoperable. He had an ampullary cancer which was picked up later on the endoscopic ultrasound scan, but by that time he had a significant pancreatitis, and by the time his pancreatitis changes resolved and settled, his tumor had progressed. So tissue sampling, when needed, should be considered. So EUS is also not risk-free, but the risk of causing pancreatitis with EUS is certainly lower than with the ERCP. Also, we know that the ERCP brushing sensitivity isn't great, whereas we can definitely get sample in more than sort of 9 out of 10 cases with EUS FNA and FNB. So the message from here is that if a patient needs sampling, then please do not send them for ERCP first. Try to obtain a tissue diagnosis, so prefer to get an EUS done. I appreciate some patients might not be able to wait given their elevated bilirubin level and cholangitis. So the indication for tissue diagnosis in suspected pancreatic cancer is if we believe that tissue diagnosis might impact the treatment. So cases where we have got a borderline tumor or a tumor which is unresectable, and the plan is to offer them palliative chemotherapy or adjuvant chemotherapy. In those cases, tissue diagnosis is required. In patients who are at high risk of surgery and to guide the decision management, EUS sampling can help. In cases of doubtful diagnosis, for example, focal pancreatitis, neuroendocrine tumor, lymphoma, and these days we see a lot of cases with IgG4 related disease. In those cases, you may need a diagnosis before you can plan any definitive form of treatment. And it's not indicated when we know that the tissue diagnosis won't impact the treatment. And this is what our practice is. In patients with jaundice who have a solid mass lesion, and we deem they are suitable for surgical resection, then these are the patients who go straight for resection without requiring ERCP or tissue diagnosis, because we know that if we do not get the tissue diagnosis, they will still proceed for the resection. So what is the current algorithm? In cases of suspected pancreatobiliary cancer, we want cross-sectional imaging with pancreatic protocol. If the mass lesion is seen, then we evaluate them for resectability. And if mass lesion is not seen, in those are the cases where we want to have an endoscopic ultrasound scan. And these are the ones who mostly we worry about possibility of ampullary lesion, and where certainly endoscopic ultrasound scan has a role. What if EUS is normal in patient with suspected pancreatic cancer? So can we reassure ourselves? Can we reassure our patient? If you look at the data based on these 3 studies and a follow-up of, in one case, up to 48 months, there was no cancer detected over this follow-up period. So we can safely reassure our patients if endoscopic ultrasound scan has not picked up a cancer. This does not mean that we will stop following them. So imaging follow-up is still recommended. Now, from ASG guidance, practice guideline point of view, they insist on having a tissue sample even for the resectable pancreatic cancer. So there are some variation in practice in different parts of the world, but EUS is considered in most cases these days. In our practice, mostly it's it's used for the doubtful cases and for the cases where the resection is not possible, and we have to consider either adjuvant or palliative chemotherapy. How do we obtain the tissue? We used to do a lot of FNAs. We've moved on to doing FNB, which is where we take a core sample rather than taking just aspirate. And these randomized control trial essentially shows the accuracy, safety, and technical feasibility of both FNA and FNB. I'll touch upon the ampullary cancer because this is something which hurts a lot of us. So patients presenting with non-specific symptoms or deranged liver blood test and dilated biliary tree with no solid mass lesion. So we go through the same scheme of requesting ultrasound scan, cross-sectional imaging. I personally would want to avoid ERCP, and if there's one message that I would like audience to take away is to resist the temptation of requesting ERCP if there is any diagnostic doubt. So ERCP is only a therapeutic modality, it's not a diagnostic modality. And if you are in doubt after having done all these cross-sectional imaging, then please consider EUS. So in this algorithm, EUS is right in the center because it decides whether this patient will go for resection, surgical resection.
You have 5 minutes.
Sure, thank you. Or this patient will go straight for endoscopic resection. So that's a critical decision for a patient. And I'll just quickly share another case of a 70-year-old man who was found to have this ampullary adenoma following his investigation for iron deficiency anemia. Now, in this case, it was quite a big mass lesion, and in somebody fitter would have gone for resection. However, he was not suitable. We did an endoscopic ultrasound scan, and we can see this ampullary adenoma, just only slight extension, not significant in the bile duct. He had successful endoscopic resection and has been doing really well. Now, just to touch upon the pancreatic cystic lesions, we used to do a lot of endoscopic ultrasound scan for cystic lesions. We have stopped doing them. We mostly rely on the cross-sectional imaging, such as MRI scan. And in CT, if there are any adverse features on CT and MRI scan, then we would consider for the EUS. Now, again, the take-home message here is that we should only be performing them if we know that by doing so, we will be able to make any treatment decisions. Just in the interest of time, I'll skip past some of the EUS-guided therapeutic intervention, but it's important to mention that there's a need to change the paradigm because of the poor survival with the current treatment. Systemic treatments are not very well tolerated by most patients. So if we can offer local anti-tumor treatment which have high intermediate drug level, a low circulating level, therefore few side effects. There are different agents available for the local ablation, alcohol. There are some experimental agents and also gene therapy. We have this data supports the use of the brachytherapy with the EUS-guided implementation of these particles and this fiducial marker placement, where these radiopaque metal markers are placed, which then guide the treatment of imaging guiding radiotherapy. Now, our RFA has also quite significant utility in patients with locally advanced cancer, some cystic lesions, especially the side branch IPMN or small neuroendocrine tumor.
Dr. Tehamid, 3 minutes.
Thank you very much. Lastly, I've just briefly mentioned about EUS role, which we're using quite regularly these days, is the EUS-guided biliary drainage in patients, because ERCP do fail, and it can fail in sort of up to sort of 5% in patients with pancreatic cancer. In those cases, our options are to consider EUS-guided biliary drainage because percutaneous approach also carries significant morbidity and mortality. This is another case where a large implant tumor was found, and we were then able to sort of stent him using USBD. Finally, again, as a palliative role in patients who are not responding to the pain control opioids, we can inject alcohol around their celiac plexus, causing celiac plexus neurolysis, and to alleviate their pain. There are some future possibilities which include contrast-enhanced directed biopsy and ablation, chemoembolization, cryotherapy, and combination of EUS with nodes. And there's a space to watch for EUS in role of HPV cancers. So in conclusion, ladies and gentlemen, and Mr. Chairman, EUS has evolved from diagnostic to an interventional platform. It is an important modality in the management of pancreatobiliary cancer. Future holds many exciting prospects for the interventional EUS, but controlled trials are critical to show which intervention will become valuable. Thank you very much for listening.
Thank you very much for that fascinating talk. It's quite interesting to see where EUS is headed, and obviously completely in agreement with you that therapeutic modalities with EUS are going to become quite a lot of norm in the future, especially with biliary drainages and, like you said, EUS guided resections, both for esophageal, gastric, as well as periampullary lesions. So I completely agree with you on that one. That was very fascinating. Thank you very much. We're going to open the floor to questions. So I'm going to have my co-host, Dr. Tabinder Sadaf, here as well. So if you can start her on the video. And we've got Dr. Habib Khan here. Dr. Jawad, unfortunately, had to kind of leave, but he's answered his side of the questions. I'm going to open the floor, and I'll ask Dr. Tabinder if she could ask the panelists the first few questions.
Thank you very much, Dr. Irfan. Thank you, Dr. Nadeem and Dr. Habib, for these wonderful talks. We have a couple of questions. First one is directed to Dr. Habib, and it is regarding the dose escalation in rectal cancer. So while we are moving towards wait and watch therapy in rectal cancer, do you think total neoadjuvant therapy with a dose escalation with SIB is a feasible approach? And if yes, then what dose escalation, what level of dose escalation are we looking at?
The main thing is when you're escalating the dose, you're looking at what you want to achieve is a complete pathological response. It depends. So one yardstick can't be used for every cancer. So the low rectal cancers have a different approach towards it. You can, if you raise the dose that you're giving to the low rectal cancer, the complication rates are going to be very higher, which include sphincter control, urinary controls, and other comps. So you have to be very careful. What SIB, if you're using SIB, then definitely you need to use the newer technology. So you need to be aware of dose what dose you're giving to the organ at risk, and you have to make sure. So how much is beneficial in terms of getting it? We know from the meta-analysis that, and there are few randomized trials, which are usually based on the South American Habagama series, which show that if you raise the dose more than 60 or 60 grays, they do have a complete pathological response. But if you look at the toxicities of those people, they have a hard time. If you're going for surgery, I know post-operative complications are much higher. So you have to balance it somewhere. That's one thing. Second thing is yes, there's a role of increasing the dose in complete pathological response. Do we do it in the setting of wait and watch? So wait and watch was not a standard option till recently being included in NCCN guidelines. Still not a standard approach. So you have to take a multimodality approach. You have to look at all the things. How are you going to assess the patient upfront? What modality you're going to use for follow-up? And how frequently you're going to do it. So these are the questions still not answered. So if a couple of my patients, I'll just tell you one case report, case which we did. So he's an elderly gentleman. He does not want to have a stoma because it will affect his quality of life. So, and it was a T3 tumor, early T3B-C tumor. So we discussed what options we can give him. So we approached in a way which was not neoadjuvant approved. I'm talking about a couple of years ago. So what we did, we offered him the radiotherapy long course. We assessed the response. The response was not good enough for him to have surgery at that time. So we given him chemotherapy at that. So chemotherapy made it shrink quite reasonably well, and it disappeared. And then we contacted Professor Min at Clatterbridge, Liverpool, and he given the boost to the area which was only luminal tumor which was visible. There was no other thing. So that made his cancer control for about 3 years very well. So that's something that you have to, but you have to see that even if you can't see radiologically, that doesn't mean you have a complete pathological response. So you have to make sure the patient understand this bit. If you don't explain it to them, then obviously it can come back. When it comes back, the options of surgery and everything as you delay become more complicated. So these are the issues which still not answered by the randomized trials. Coming back to the main thing, are that we're going to use it with the TNT treatment? That's up for the grasp. Or if you want to start a trial, so obviously we can get an answer, but you need to have a number. And number two is still wait and watch policy has to be very carefully monitored with the follow-ups. Obviously, clinical examination, endoscopic ultrasound, MRI scan. Now we got diffusion weighted, so we can predict much more accurately in terms of cellular level how much encroachment, how much the tumor is, how much normal or how much fibrosis is. So these things have to be looked into. I think case-to-case basis, you need to consider. If you can use other modality like a contact radiotherapy to increase the dose. So for contact radiotherapy, you can go up to 90 grays of the boost local with KV, and you know you're going to spare the long-term like sacral insufficiency fractures, sphincter problems, and all these symptoms that side effect you can avoid. So you try to look into those kind of things. So you have to balance it according to the patient's need and what patient is. And then we don't have the evidence yet to incorporate into the TNT. Most of the people you've gone up to 50.4 grays. They haven't gone above. I think chemotherapy sensitizes the radiotherapy, so you have to be keeping this mind as well when you're escalating dose. Either you're gonna use it with the safely or not. So you have to have a safety kind of measures before you can use it. So there's a role, but still we have to look at the board, what evidence we get, and then we try to work around it.
Right. I've got a question next. I'm going to take for Dr. Tihami. It's a combination of two questions. First is from Dr. Manan, and she's asking about the chances of tumor seeding due to USFNA for pancreatic cancer. And the second question is just an add-on to that from Dr. Sabine Farhan, who's one of our gastroenterologists. And she wants to know that if you have a patient with pancreatic cancer who has a bilirubin of less than 10, would you recommend stenting prior to surgery or directly for surgery?
So let me answer the second question first, because as I said, interventions carry a risk. And if there's a potential risk of making an operable cancer an inoperable one, then we have to weigh the risks and the benefit. And our surgeons, Mr. Ahmed has left, but I'm sure he would have supported me. These days do a lot of hot Whipples. So when the patient present, they try to get them resected within sort of 2 weeks time. So if a patient can have Whipple resection in 2 weeks time, and you've got enough evidence based on radiology, patients presenting and presentation and other markers, then yes, you would proceed for that and would avoid doing ERCP and biliary decompression. However, if patient clearly is very symptomatic, or you know the surgery is going to be delayed, then I guess you have no option but to go for biliary decompression. But if there's any doubt in the diagnosis, then as I said, you always want to do an EUSN diagnosis first before you do an ERCP, because ERCP brushing yield isn't really good. So that's important. There is also a school of thought which are considering and suggesting that we should even avoid going anywhere close to the ampulla and going straight for other options of EUS guided biliary drainage, even as an index biliary decompression procedure. So that's where we are. You have to be guided by your surgeon, and this is where the QPI, these first QPI comes in. That is your MDT, your multidisciplinary team, your surgeons, your radiologists, your oncologist. Everybody have to be on board. In terms of the seeding risk, that's a very important question. We've got data. I think there was a nice paper published, I believe, 2 years ago, which showed that, I mean, it is more of a sort of a theoretical risk. If we haven't got enough data to sort of suggest, or we don't have a concrete evidence to say for definite that these patients develop tumor seeding after having an EUSFNB. But again, having said this, if you've got a clear-cut tumor, I mean, we come across many patients who have got a lesion either in their. So this apply mainly to the body and the tail of the pancreas tumors, because that's where you're going to access the body and the tail from the stomach. If it's a head tumor or a neck or uncinate, head and uncinate, you're going to go through from duodenum. And when they're doing pancreatic duodenectomy, that part comes out anyway. So obviously, it only applies to the pancreatic body and tail. And our surgeons sometimes just again go straight for the resection and take them out. But as I said, as far as my reading on the data is concerned, it is only a theoretical risk. However, having said this, I would not encourage people doing it without having discussed it with their MDT.
Dr. Tabinda, would you like to ask the next question?
Yep. So, Dr. Habib, there is, if we have given a total neoadjuvant therapy in patients and then post-surgery, there is significant residual disease, I would say a high nodal burden is still there on pathology. What will be your choice of treatment in adjuvant setting in those patients? Is it just wait and watch? Because they will be, definitely they have poor prognosis. So,
It depends what you have used in the total neoadjuvant treatment. So if you're using FOLFIRINOX.
FOLFOX, yep. So we use FOLFOX most of the time.
So if you use FOLFOX upfront chemotherapy, then you have still a role. If you, how many months you use? Either you use 3 months of treatment before, 4 months of treatment. What did you do for the assessment? That's what the question you need to ask. If they were non-responder, usually if they respond to chemotherapy, they do respond to radiotherapy as well. So sensitization point of view, if you look at the radiobiologies behind it, so you know when the people are responding to the chemotherapy. So if you have chemoradiotherapy only, if you're talking about because total neoadjuvant, you have to keep in mind you are giving upfront chemotherapy, chemoradiotherapy, and then you're talking about adjuvant treatment. So if they have used about like 4 months or 3 months, that there might be some consideration of giving some more treatment, but depending on how much is the burden. But if you already have done, there are two schools of thought, escalation and de-escalation, people all talk about. So if you know they already not have responded to chemotherapy, how much benefit you're going to provide them with giving extra similar double agent, because there's no role of irinotecan in adjuvant setting. So you're going to be using oxaliplatin-based chemotherapy. And you know that you use 5-FU up front anyway. So capecitabine on its own role does not exist. So is a kind of case-to-case basis. So if you've got a positive margin, then obviously resection margin, then you're positive, then you'll be thinking something different of your extracapsular spread or pelvic side wall that you're looking into. That, or if you have given radiotherapy adequately, then you might have boosted that the side wall node. Usually it's the side wall node that usually gives you a problem, which is a recurrence point of view from the surgical area. So I think there is some role. It's not clearly defined. You can use doublet agent rather than using single agent. Then you need to think about MMR deficient patient. Yeah. So if you're dealing with the MMR deficient, then obviously you should have assessing them every 2 months when you're giving chemotherapy up front. So we always get MMR from the first diagnosis. So we know exactly how to approach these patients. We know sometimes they're not going to respond. If they're not responding, then obviously if you haven't given upfront, then definitely there's a role to do it. Sometimes you give chemoradiotherapy and you find out you don't have adequate response. So what would you do? You either gap with the chemotherapy because you don't want a positive margin. You want to get it retracted back. So you want to do it either with chemotherapy. Most of the time you sensitize the tumor after giving radiotherapy and they respond. So apart from 1 or 2, most of the people who did not respond chemo, when we're giving chemoradiotherapy, when we give the in between before the surgery, we're giving some chemotherapy and they have retracted very well. Either you can argue it's just because of the weight or it can be the chemo, but we are happy to take the credit either way around because we do chemo and radiotherapy both. So.
Okay, thank you.
Last question. I know Dr. Sabin's already had an answer sent to her directly by Dr. Tehami regarding the contrast enhanced ultrasound. But the last question I have for you is from Dr. K. Aftab, who says, is there any role in distinguishing a T3 from a T4 renal tumor with duodenal involvement? And I think that would be directed towards Dr. Tehami.
Yeah. No, thank you very much for that very important question. So apologies, I didn't cover this in my talk, but the role of EUS in staging is limited. At least in our practice, we do not rely on EUS in staging the disease. However, there is a data out there which supports that EUS with CT and other cross-sectional imaging should be the way forward for staging the disease. So as it stands, we mostly rely on CT scan to stage the disease. But you're absolutely right. CT would not tell you in terms of the significance or the involvement of the duodenum. the ultrasound scan, EUS can help, but the problem is by the time it starts involving the duodenum, it causes duodenal narrowing, it causes duodenal obstruction, and therefore sometimes it's really hard to even get into the D1 or D2. So you can't sometimes pass the pylorus, and patients start developing symptoms of gastric outlet obstruction. So in my practice, as I've seen it, that by the time duodenal involvement happens, it's far too late. And technically speaking, hopefully once we've got a better scopes, because the EUS scope, as they're hard to manipulate or maneuver compared to some of the other scopes. So as it stands, it becomes really challenging to stage the disease with EUS.
Okay, perfect. I think that's all for questions, and I think that we're coming to the end of our session. I would like to thank Dr. Tabinder for co-hosting the session with me, and definitely a huge thank you to both Dr. Tehami and Dr. Habib Khan for joining us all the way from their respective places and so early in the morning. I think this has been a very informative session, at least for me and for everybody else involved. We've heard about new treatments in rectal cancer. We've heard about the evolving role of a US and the management of pancreatic cancer, which has definitely changed over the past few years, and it might change again in the next couple of years. So thank you very much all for joining us, and we'll close the session now.
Thank you very much. Thank you so much.
Thank you very much.